And welcome to our presentation this night before the Easter holiday. And we are welcoming Lantheus, Dr. Daneil Kuftinec, MD, who will present diagnostics, radiopharmaceutical oncology, diagnosis, and therapy. Um, we are delighted to have the doctor here. For more than 65 years, Lantheus has been advancing patient care by learning, adapting, and making advancements across the healthcare spectrum. Dr. Kuftinec had joined Lantheus in March of 2022 from Leahy Hospital in Massachusetts. There she served as a board-certified urologist in clinical practice for 15 years. Dr. Kuftinec received her medical degree from Tufts University. She's completed residencies at Boston University and its affiliate Boston Medical Center, Boston Children's Hospital, and VA Boston Healthcare Hospitals.
Thank you. I really appreciate the opportunity to have this discussion here tonight. The further I get out from clinical practice being with patients, the more I really do cherish these opportunities. So I appreciate it. I'm going to share my screen here and we will get going. Let's see. All right. So once again, thank you for having me. This presentation is for men with prostate cancer, their families, friends, caregivers, and it's really designed to make clear the role of advanced prostate cancer imaging for patients and other stakeholders. As far as disclosure, I am a employee of Lantheus. I'm Dr. Kuftinec, as I was so nicely introduced. And basically, we'll be talking about on-label indications for prostate cancer imaging with our agents. I'm happy to answer any questions that could extend beyond that in addition. And so our agenda today is to give an overview of prostate cancer, to talk a little bit about prostate cancer screening, and then to talk about diagnostic imaging for prostate cancer. And so I'd like to start by introducing you to our patient of the evening. This is Greg. This is a representative case. He is not an actual patient, but for our purposes, Greg is a 62-year-old African-American male and a U.S. veteran. He takes medicine for benign prostate hyperplasia, or BPH, but otherwise considers himself to be in good health. He goes to the VA every year for a physical, and about 10 or so years ago, during his routine exam, he was noted to have an elevated PSA, or prostate-specific antigen. And it came back just slightly elevated. It was 4. He was 62 at the time again. And although this was a little bit higher than usual, a PSA of 4 is still considered to be borderline high, borderline normal high. And so he and his doctor at that point, through shared decision making, decided to monitor his PSA and not be too concerned about it. And of note, just to further flesh out Greg's history, he has 3 brothers, and recently 2 of his brothers were actually diagnosed with prostate cancer. So just going through a little bit about prostate cancer, it's common. It forms in the tissues in the prostate. Just a little bit about normal prostate anatomy. The prostate is a typically walnut-sized gland of the male reproductive system. It lives right between the bladder and the urethra. You can see here in the representation, the prostate is this sort of darker salmon-colored area, and it actually encompasses the urethra, kind of like an apple, and then the urethra would be the core going through the apple, which would be the prostate. It lives in front of the rectum and underneath the bladder, or below the bladder anatomically. And more than 260,000 men in the United States are diagnosed with prostate cancer each and every year. And that sort of translates to about 13 out of every 100 American men will be diagnosed with prostate cancer sometime in their lifetime. And Greg, at this point, the way that his PSA is behaving, as well as his family history, he could be one of those men. And so he does have a higher risk of prostate cancer than all comers if we looked at the entire male population. African-American men like Greg are more likely to get prostate cancer. They're likely to get prostate cancer at a younger age. The average age of diagnosis is a little bit younger for African-American men than it is for the general population of men. African-American men tend to have more advanced prostate cancer at the time of diagnosis. And their prostate cancer seems to be more aggressive from time of diagnosis throughout the sort of course of the prostate cancer patient journey. And that really translates that African American men are more than twice as likely to actually die of prostate cancer than other men. And so screening tests are used to look for prostate cancer before it causes symptoms. And there are two screening tests that we use for prostate cancer. I'm sure you're all very well aware of these. It's the prostate-specific antigen test, or PSA, as well as a digital rectal exam. And the PSA test is typically a part of routine annual physicals for most men. Most men after age 50, and then men with histories of family histories of prostate cancer, and men with other risk factors can start in their 40s or as early as 40 with PSA annual testing. PSA is a blood test. It measures the level of prostate-specific antigen in the patient's blood. And PSA levels are not specific to prostate cancer. So there's not a direct correlation between having an elevated PSA and then certainly having prostate cancer. PSA is non-specific. It can be also associated with an enlarged prostate. It could be associated with having recent physical activity, bicycling, strenuous activity, weightlifting, sexual activity. It can be associated with inflammation or infection in the prostate. So it's not specific to prostate cancer, but a high PSA could also be an early sign of prostate cancer. And the reason mostly for that is because prostate cancer cells are not like normal prostate cells, and they just allow the PSA to leak out of them a little bit more easily. And so more of this just sort of seeps into the bloodstream. The other second type of screening test for prostate cancer is the digital rectal exam, or DRE. And this is performed by your healthcare provider, either your general practitioner or your urologist, by inserting a gloved, lubricated finger into the rectum, where you can feel the prostate and tell whether there are any irregularities that could be a sign of prostate cancer. So when we're feeling the prostate, what we're feeling is for any hard areas, any nodules, any asymmetry to the prostate, that can all be indicative of prostate cancer there. And so, as I said before, these screening tests are typically ordered by primary care physician, family physicians, general practitioners, but they can also be ordered by a urologist if you're routinely followed by a urologist for any other reasons. So let's fast forward 5 years later. So, Greg initially had that PSA of 4. So he unfortunately missed a couple annual physicals due to the pandemic. And he reappears and reconnects with his primary care physician. And in 2021, his PSA has jumped to 5.3. And so again, through shared decision making, his general practitioner sends him to a urologist for further evaluation. The urologist evaluates Greg and takes his history, notes his elevated PSA, notes that it is going up, and also notes that he is African American and has a family history with 2 first-degree male relatives. And so the urologist orders a prostate biopsy to be performed. So prostate cancer is diagnosed by having a prostate biopsy. So there's really no other way that we have of diagnosing prostate cancer. It has to be with tissue. We can't do an imaging study. We can't do a blood test. We can't do it by rectal examination. It really is by getting, samples of tissue, removing them, sending them to pathologists to look at. And that's the really only way that we have of diagnosing prostate cancer. And so in the prostate biopsy, it's either done by transrectal or transperineal approach. This shows a transrectal ultrasound probe, but actually a perineal approach of obtaining the prostate tissues. That's the prostate biopsy there. The ultrasound probe in the rectum allows for really great visualization of the prostate. And as I said before, anatomically, the prostate lives right in front of the rectum, or the rectum lives right behind the prostate. So, it's sort of we're fortunate that it is, the prostate gland is in an anatomic position or location that we can access it this way. And so typically anywhere from 12 to 24 cores can be removed, or any combination in between, upwards of 24 even, can be removed in order to diagnose prostate cancer. The tissue that's removed is sent to a pathologist, and they examine the tissue under the microscope. Sometimes they do special stains, and they diagnose either cancer or benign tissue. If cancer is found, it's given a Gleason score, and that's a way of the pathologists describing to the rest of the care team and the patient how aggressive or non-aggressive the prostate cancer seems to be. And the Gleason score right now ranges from 6 to 10. It's made up of two numbers. The first number denotes how the most predominant sort of pattern of prostate cancer cells that the pathologist sees, and the second number denotes the second most predominant pattern of prostate cancer cells that the pathologist sees. And so the combination of either a 3 plus a 3 gives you this 6, which is the least aggressive that we see. And then a 5 plus a 5 would show you that that's really along the lines of the more aggressive prostate cancer that we see. It says here that a lower score means the cancer is less likely to spread. I tend to think of it more in terms of a lower score just means less aggressive prostate cancer. And along with that come all of the additional sort of factors of less aggressive versus more aggressive. Less aggressive to spread, more options for treatment, maybe even surveillance, that type of a thing. So again, as I was saying, when the pathologist looks at the prostate tissue under the microscope, they assign these grades, one to the most common cancer cell pattern that they see, and then they assign a grade or a number to the second most common cancer pattern that they see. And we add these two numbers up and we get the Gleason score. And the Gleason score of 6 or less means that there's low or very low risk that the cancer is going to grow and spread. It's less aggressive. A Gleason score 7 means that there's sort of this intermediate risk associated with the cancer that's there. The intermediate is it's a really unique risk score that we give prostate cancer, and you can see that it's separated between favorable and unfavorable. Favorable, it has a 3 before a 4. Unfavorable has a 4 before a 3. Again, that's looking at the most common pattern and the second most common pattern. So even though they're both a Gleason score 7, they actually they give us different information from the pathologist. And a Gleason 7 from a 4 plus 3 tends to behave differently than a Gleason 7 from a 3 plus 4 score. And that's really a branch point for a lot of different treatments and sort of risk stratifications for patients. And so that's a really important sort of differentiator there with regards to the Gleason score. And then we see a Gleason 4 plus 4 would equal an 8, and a 4 plus 5 would be a 9, et cetera. 5 plus 5 is 10. When we get a Gleason score, it also translates to what we call a grade group. That's that middle column. So a grade group 1 all the way to a grade group 5. And it's a little bit more of a standardized way of us looking at these risk stratifications. And what you can see is that, you know, if we look at intermediate, where they're both Gleason 7s, they actually have different grade groups. One is a 2 and one is a 3. So again, it's further differentiating those. So for Greg's actual pathology results, he had a 12-core biopsy, and the biopsy revealed 3 samples where there was prostate cancer cells noted. And then there was a 4th sample with more sort of aggressive looking cells. And that one was the 4 + 4 = 8 pattern there. And so his actual diagnosis is prostate adenocarcinoma, a Gleason score 8, and a grade group of 4. And so that's sort of how his prostate cancer would be described pathologically, and that's how it would translate into his risk stratification. So a person's risk group or their risk stratification really guides the treatment plan for the patient, and it's based on several criteria. So it's based on the PSA level. This is, you can see on the left-hand side, the risk group, and then the PSA level. It's based upon the Gleason score, indicating the aggressiveness of the cancer. It's also based upon the size and location. And so men with a PSA less than 10, a grade group of 1, which means a Gleason score of 6, are in the low or very low risk group. And their cancer is smaller, it's localized to the prostate, it can't be felt when a rectal exam is performed. In patients with intermediate prostate cancer, they have a PSA, and again, this is this risk group differentiation between favorable and unfavorable. And what you can see is that favorable patients have a grade group of 2, which means that they have a Gleason 3 + 4 = 7. Their PSA is less than 10. And patients with unfavorable intermediate risk prostate cancer have a higher PSA range, 10 to 20. They have a grade group 3, which means they're a Gleason 4 coming first, and then 3 = 7. And this starts to indicate that the cancer is getting bigger. It might have even spread beyond the prostate. We're really not sure. And they probably need some further evaluation in order to really figure out what's the best treatment course for them. And then men with a PSA greater than 20, a tumor grade of either 4 or 5, so these are the Gleason 8s or 9s or 10s, are in the high risk group or the very high risk group. And in general, these cancers are bigger. They tend to be thought of as growing outside the prostate or having some local advancement, possibly spreading to the seminal vesicles or into other tissues adjacent to the prostate as well. And so while at the VA hospital, Greg's urologist ordered several imaging tests for him to provide additional information about his prostate cancer and where it might have spread to. And this really would have been the typical next step for patients at initial diagnosis who were in the intermediate, unfavorable, high, or very high risk groups prior to like 2022. In 2023, the guidelines of the NCCN, which is the National Comprehensive Cancer Network, came out indicating that PSMA PET scan could be ordered earlier. And so it could be ordered within this area where Greg is, in the intermediate, unfavorable, the high or very high risk prostate cancer. And the reason why those guidelines shifted and they started to recommend PSMA PET scan in place of either CT scan or MRI or bone scan was because based upon the data and the trials, PSMA PET was noted to be equally effective, if not more effective, as a frontline imaging tool for prostate cancer. It was one test as opposed to a combination of tests in addition. But Greg wasn't in this era at that point, and so he had a CT scan, an MR, and a bone scan. And unfortunately, these tests showed that Greg may have also had lesions in his pelvic region, in his ribs, shoulder, lymph nodes, and liver. And so these indicated that he might have had really sort of widely disseminated prostate cancer, unfortunately. So at this point, based upon the results of Greg's latest scans, his urologist might have referred him to several other specialists to help with his care. And so Greg could have been referred to a medical oncologist, a radiation oncologist, or even a nuclear medicine specialist, or simple radiologist as opposed to radiation oncologist. And these types of specialists and subspecialists could have made up his care team overall. So let's talk a little bit about advanced imaging, and that's what we're here really to highlight and bring forward. And so advanced PSMA PET-CT nuclear imaging can provide more detailed information about your prostate cancer than standard imaging. So the standard imaging, again, is CT bone scan, in some cases MRI, but usually it's CT bone scan. And so the PSMA PET nuclear imaging targets PSMA and may find cancer that's missed with standard imaging. So the PSMA PET CT is a positron emission tomography / computed tomography. That's the PET CT portion. It's a type of nuclear imaging that uses a tracer that is injected into the patient, and then it travels through the bloodstream and it attaches to this protein called PSMA, prostate-specific membrane antigen, found on prostate tumor cells. And like I said, it can be considered more accurate than imaging about the location and extent of prostate cancer, both in bone and in soft tissue. It actually uses less radiation than standard imaging. It works quickly, it leaves your body quickly. And guidelines, as I said before, including the NCCN, have really come forward over the past few years, stating that because of this increased sensitivity and specificity of PSMA PET compared to standard imaging, it can serve as an equally effective, if not more effective, frontline imaging tool for prostate cancer. And so a lot of people hear nuclear medicine and radiation, and you worry about your exposure. And the average American is exposed to about 3 to 6 what we call millisieverts of radiation each year from natural sources such as the sun and radon. And Americans are also exposed to radiation in daily life from our televisions, our computer monitors, cell phones, smoke detectors even, and airport security cameras. And medical imaging really only slightly increases a person's total lifetime exposure to radiation. So again, it's in general low dose of radiation. It leaves the body quickly. It doesn't put additional people at risk that are around you, et cetera. And really what we know is that more precise imaging can lead to better treatment planning and targeted care. So if PSMA PET imaging has higher sensitivity and higher specificity to find prostate cancer, then we can offer better treatment planning and hopefully targeted care, and that should result in better outcomes for patients. And without this successful treatment, prostate cancer, unfortunately, can spread to other parts of the body. We know that outcomes are best when prostate cancer is treated before this occurs, before it spreads. And we know that outcomes worsen as disease does travel to other areas, the pelvic area, lymph nodes, or even bones and other parts of the body. And we also know that this advanced nuclear imaging can help you and your doctor make informed treatment decisions, again, that lead to the best possible outcomes. And so targeting PSMA or this prostate-specific membrane antigen can help improve decision-making. As I said before, PSMA, very different from PSA, which is a blood test, but PSMA is a protein made in the prostate that can help diagnose prostate cancer by visualizing it outside the prostate. PSMA exists on the surface of most prostate cancer cells. And what happens is PSMA also exists on normal prostate cells. But in normal prostate cells, it exists inside. And there is much less PSMA made by normal prostate cells. When a prostate cell becomes cancerous, so it's now a prostate cancer cell, it starts expressing this PSMA protein actually on the surface, and it expresses a lot, it overexpresses it. So it makes it a really ideal target for imaging. So what we have is we are able to target it. We have our imaging agents attached to the PSMA that are on the surface of cells, and they sort of do their magic and they light up the images on the positron emission tomography, computed tomography. So it's really a reliable target for detecting prostate cancer. And so PSMA PET imaging helped guide Greg and his doctor actually to a better outcome. And so his PSMA PET scan showed that Greg's cancer was only in his prostate. It had not metastasized to his pelvic region, his ribs, his shoulder, his lymph nodes, or his liver, which all really would have denoted a very, very aggressive, already metastatic prostate cancer. And these spots that were seen in his earlier imaging were unusual, but they weren't signs that his prostate cancer had spread. And so Greg and his doctor were able to plan a course of treatment that was appropriate for him, using, again, a shared decision-making approach. With having localized prostate cancer, Greg has a whole additional, sort of array of options for treatment, which would not have been the case had he had this is really, systemic disease, as his other imaging was pointing us toward. So PSMA PET CT imaging also helps men with recurrent prostate cancer. And what we know is that within 10 years of treatment for prostate cancer, so this is either radiation or surgery, 20% to even 50% of men may experience a recurrence. And men with a genetic or a family history of prostate cancer have a higher risk of recurrence after surgery. But PET scans may provide better accuracy and precision than CT and MR scans for detecting prostate cancer recurrence. So just like in the initial staging with Greg, in the recurrent space, we also know that they have improved accuracy and precision. And PSMA PET scans are effective for early detection of recurrent prostate cancer. So this is even when PSA levels are as low as 0.2. PSA is indicated for men with suspected prostate cancer recurrence just based upon a rising PSA. So if you've had treatment for your prostate cancer, say you had surgery, your PSA goes to undetectable, and then a year later to 10 years later to 15 years later, you start to see sort of an increase in the PSA. It can be an increase even as low as to 0.2, and that could trigger a PSMA PET scan that could give valuable information. So unlike standard imaging, as I've said sort of over and over again, PSMA PET imaging is effective both in bone and soft tissue, and it can identify tumors even when they're small and, as I said, when PSA levels are low. And so whether you have newly diagnosed prostate cancer or recurrent prostate cancer, when it comes to diagnostic imaging, you have many choices, as this imaging chart shows. You have PSMA PET scan, you have a CT scan, you have MRI, you have bone scan. And the important thing really is to know what your options are so you and your doctor can work together and choose the diagnostic imaging that works the best for you. Successful diagnostic imaging may lead to a treatment plan that makes more sense for your disease, as we saw with Greg. It can also lead to earlier treatment and a better opportunity for that treatment to be successful and in both initial staging and in recurrence. And different options have different benefits. So it's really important to discuss them with your doctor. And I guess what this chart is really saying is that the PSMA PET, or the advanced nuclear imaging, really checks off all of these boxes. It detects cancer in your bones, in soft tissue, when it's small, and even when PSA are very low. And what you can see is that the other more traditional imaging modalities, they do check off boxes, but really none of them check off all of these boxes, and they probably don't have the same specificity and sensitivity that we see with PSMA PET for looking at prostate cancer, both at initial diagnosis or staging, as well as in the recurrent space. And so I just wanted to, before we end, share with you some of these helpful resources. A lot of you are probably aware of these, but I really find that, I think that these resources, what I found, when I was working closely with patients, particularly, at time of initial diagnosis, at the time of that first recurrence, second recurrence, third recurrence, et cetera. Information is key, and talking to people is key, and making choices that make sense for you and your family are really, in my opinion, it's the best thing you can do, is to make an informed choice that that works for you. And so again, these are just some resources that we put up there, and I really want to thank everybody. So I guess we'll open it up for questions at this point. There we go.
There we go. We have a few questions here.
Oh boy. All right.
First is a question from Stephen, who's, I think, really asking the question, where do I pull the trigger on PET, PMSMA, and who do I pull the trigger with? Because he's saying, how do I locate facilities? But really, it's not a facilities issue so much of it's which one of my PCA treatment providers and when.
Yeah. So the all of the currently FDA approved available PSMA PET imaging agents have the same indication in recurrence. So I'm assuming, Steve, you mean in recurrence. Is that correct?
Steve, if you want to unmute, you could talk to the doctor directly. There we
No,
go.
I'm not recurrent. Basically, I'm just trying to get a better picture of what my status is. I've done regular ultrasounds, and I know I've got an irregularity there, but I haven't got a very good definition of what it is.
And you have been diagnosed already? You have a diagnosis of prostate cancer?
No, because I've never had a biopsy.
Okay, so the on-label indications of all the currently approved PSMA PET imaging agents that are commercially available, the indication is for men with prostate cancer. So it's indicated that you already have the diagnosis of prostate cancer to have a PSMA PET scan on label. And for at the time of initial diagnosis, according to current guidelines, it's if you have suspected metastases at the time of diagnosis. That's a very broad description, right? So what we've done is we've really sort of honed in on what does that mean and how does that translate to utilization within the guidelines. And what most clinicians follow for that are the NCCN guidelines of patients at time of initial diagnosis having intermediate unfavorable risk prostate cancer, high risk prostate cancer, or very high risk prostate cancer are on label indication for PSMA PET imaging at the time of initial diagnosis. But in general, it's really the payers that would not support having a PSMA PET scan prior to diagnosis at this time. There are some trials exploring the use of PSMA PET imaging in combination with or in comparison with MRI. So MRI, as we all know, is used for diagnosis because it can help guide your biopsies. We're not there yet with PSMA PET imaging. Eventually, we probably will be. It might be alone or it might be in combination with an MRI for diagnosis.
So how do I sign up for one of those trials?
Yeah, so one of the best things would be, so you're currently seeing a urologist or a general practitioner?
General practitioner.
Okay, so I would probably ask to be referred to a urologist to see if you can have some further evaluation with a urologist. And at that urologist, I would ask for any clinical trials that are looking at PSMA PET imaging for diagnosis.
Okay, good. Thank you.
That would be my recommendation. Yep.
Thank you very much.
Yep.
We're going to go to Bob. And Bob has a question about LASIK. I don't know if you could see it in the chat there. And that whether LASIK is standard procedure for PSMA. Maybe it should be.
Okay, yes.
I can read it, but
yeah, I see it there. So leaves the body quickly. I've heard that it makes it harder to evaluate the area near the bladder. One PSMA PET CT I had, they gave me intravenous LASIK to clear the bladder before the scan. Should this be a normal occurrence? So We are fortunate in our sort of in our package insert, according to the administration. So our approved package insert that gives administration guidelines or recommendations. You do not need to give Lasix. So you know, there are other imaging agents and PET imaging agents where you do give Lasix beforehand. We recommend, and this is true with all of the currently again FDA approved imaging agents commercially available. They all say that you need to hydrate. So you need to hydrate before the exam. You should try to void right before the exam, and then you void frequently afterwards. That's to clear it quickly. Voiding before the exam helps to mitigate what you, I think, are mentioning here, to clear the bladder before the scan. And so it's nice to have an empty bladder because when you're looking at the images, the radio tracer, for all of the agents, it's filtered by the kidneys and it's put into the urine, and then it travels down the ureters and it sits in the bladder. If you empty your bladder right before your scan, it's ideal because then you have all that radio tracer leaves your bladder and you've got a clear window into the area, one where the prostate is or where the prostate used to live. And that can, you know, those are important areas for basically also, you know, for recurrence. So I think it's fortunate that we don't have Lasix in our protocols where we have to give it, because it does make it smoother. It's IV. I mean, you know, all those things. And then honestly, you're going to the bathroom for hours afterwards, right? But some practitioners, if they are particularly concerned about the area around the bladder, where the prostate used to live, for say you had a prostatectomy, it's called the prostate bed. If you're particularly concerned about a recurrence in that area, they will give Lasix in order to clear your urine a little bit more quickly, make you have to go to the bathroom, so to speak. Sometimes as a urologist, that's fraught with some uncertainty because we all know, you know, voiding sometimes isn't easy when you have an enlarged prostate and, you know, potentially prostate cancer. And, you know, so, you know, it's sometimes a plus or minus there.
Thank you, Doctor. Phil is looking for some answers, as many of us are, for high PSA absent evidence of PCA. So he's gotten some good news out of his PSMA and maybe is looking to physical activity in his prostate that could stimulate more PSA, nodules, benign stuff.
21, yeah, okay, I see this. This is grade 1, negative PSMA test, great, but PSA is 21. Yeah, so, you know, PSA is good, but it's not perfect, right? And it can be, as I said, elevated for all the other reasons listed. It could be an enlarged prostate. It could be your exercise. It could be inflammation. It could be irritation at any given time. What I recommend, negative PSMA. Oh, no, I'm looking at the one. Okay. So yeah, so it could, so all of those reasons could be high PSA. I think it's what you have here is a little bit of discordant information. So you have Gleason 6 prostate cancer. So you have a grade group 1. So it doesn't look very aggressive. It's low risk. And you have a negative PSMA PET. So those excellent track record under your belt. Your PSA is what's discordant. The PSA, I agree, is high for the other information that we have. And so I think that, yes, I would look at some of those other reasons. I think for you, it could be the prostate being enlarged. I would be, if that's the case, if you do have an enlarged prostate, if that's the case, there are a couple of things that you can ask your urologist if they've looked at. You know, have they looked at your PSA density, which is the ratio of your prostate PSA to the prostate gland size. The lower the PSA density, the better. The higher the PSA density, it means that it's a small gland making a lot of PSA, and that's a little bit more concerning. I think you could also look at your PSA velocity. If your PSA velocity has been pretty steady, that's also another reassuring factor to place in there. And I would be really, really, really diligent surrounding your PSA testing to make sure that you do not have any strenuous activity or sexual activity within 24 to 48 hours prior to PSA testing. Because all those things can increase your PSA, give you a false high.
I've had urologists say hydrate before you take a blood draw on PSA. I'm not sure.
It shouldn't hurt it because it's not really looking at your, it's not looking at your like a hemoglobin concentration. It wouldn't really affect it in that way. But I think hydrating is not a bad thing as long as you're not straining to void. If hydrating for you personally, if anybody has an enlarged prostate and they're hydrating and they're voiding more frequently and you really have to strain to void, well, you know, that, you know, it could counteract what you're trying to do.
Well, my prostate is 67.
67, it's a biggie.
Yeah, prostate
thank
size.
you.
Yeah.
And the other thing is hard bowel movements enter into this as well.
Absolutely. Absolutely. Yeah. Make sure you're, you know, trying to keep your bowel movement soft around the time of PSA testing, et cetera. It's hard, but yeah.
You might even want to say, try to maybe use a stool softener
Yeah.
for maybe what, 3 days, 5 days prior?
Yeah, whatever
To
it
a
takes.
draw?
It could be even a week. It could be even a week if you have particularly hard stools, you know.
Okay. Yeah, the mystery of PSA.
Yeah.
Now I have what looks like another question from Bob. Do you have any clinical trials for the use of PSMA to do the treatment?
Yeah.
When we use a phrase like do the treatment in line with a diagnostic, the word that flashes in my head is theranostics, not
Yeah. So
PSMA.
yep, I know where this is going. So yes, so PSMA can be used as a target for actually radioligand therapy. So theranostic denotes both diagnostic and therapeutic treatment, and PSMA is both a target for diagnostics as well as a target for the therapeutics. And so yes, there are ongoing trials for PSMA targeted radioligand therapy. Again, I would encourage you, you know, ask your urologist what's available in your area and at your hospitals, but absolutely. It's a really, really, really very important and active area of research right now.
Excellent. We have a question from Steve, who is different from Stephen. I had a PSMA test and they found 2 lymph nodes that were radiated, but the PSA had risen from 1.3 to 2.21 in 7 months. I expected it to go down, not up, and I was wondering why.
Yeah.
I want to bring Steve on to talk about his experience. Are we talking here about a bump, Stephen? A post radiological treatment bump, which will go away? Or are we talking about we're looking for more cancer there? We're not sure we got the cancer.
Yeah, well, like I said, 7 months ago, I had the PSMA test, and then about 2 weeks later, I had they found 2 lymph nodes, and they were radiated, and but the PSA keeps going up.
How do you know the location of the lymph nodes?
No, I do not.
Okay.
They were on the sides.
In the pelvis area?
Yes.
Okay. Okay. Yeah, I agree. The expectation is that if you radiated the visible disease and treated it, then the, you know, logical that the PSA would go down. Prostate cancer, most prostate cancers express PSMA. Not all prostate cancers express PSMA. So some prostate cancer, if you've heard of, dedifferentiated prostate cancer or neuroendocrine variant prostate cancer, small cell prostate cancer, all of those sort of variants, they're less well differentiated than the traditional adenocarcinoma that we diagnose. And what we know is that about, well upwards of 80%, probably 90% plus of all prostate cancer does express PSMA, but there's a very small subsection that does not. And what I would say is perhaps you need to do a totally different imaging study to look for prostate cancer that's no longer expressing PSMA. Or if you were going to get another PSMA scan and you did have something light up, another lymph node, et cetera, maybe to get a biopsy of that, so that can go through some additional testing. That tissue can go through some additional testing, because there are some additional factors that we can look at that might make that prostate cancer more prone to going down the line of dedifferentiation. But the test that I'm thinking of that might show you is actually an FDG PET, which is something that we sort of moved away from in prostate cancer, but has been used in prostate cancer recurrence. And what we do find is that sometimes FDG PET can see prostate cancer that's in that small percentage where it's no longer expressing PSMA.
Okay, thank you.
Yeah.
Bob again has another question. Do you have any statistics of finding spots with a PSA of 0.7 versus 1 in recurrence after negative PSMA PET-CT at a PSA of 0.04? So it sounds like what really asking her is an accuracy question.
Yeah.
And if I'm, for whatever reason, or my healthcare provider isn't satisfied, or we've got a question about PSMA, what's my next move?
Yeah, so we do have statistics about finding recurrence at lower PSA values. And so we know that it can range anywhere from 30 to 80%, depending on how low to how high your PSA gets, under 1. Trying to follow here. So you had a negative PSMA at 0.4. And
Correct.
then did you have a repeat at 0.7 and at 1, or?
Not yet. I'm trying to figure, do we wait? Do we do it at 0.7 or do we wait to go to 1.0? And
Yeah.
I'm 10 years post-surgery. So this
Okay.
is not a short duration.
Yeah.
So it's slow. It's a slow rise.
Yeah, so again, it's looking at that doubling time, as I mentioned before, which it sounds like you're doing right now. You do have, the benefit of having a long time to recurrence typically means that this is a very sort of less aggressive prostate cancer. Sometimes there can be prostate cancer recurrence. Were you undetectable and then went to 0.4?
I was undetectable, and then it crept up.
Yeah.
Some years it crept up to 0.2 and
Yeah.
then 0.4. But
Okay.
it was undetectable for 3 years
Okay.
after surgery.
So I think of PSMA PET this way in these situations. You have to have enough of an aggregate of prostate cancer cells in order to see it, even with these agents. You need to have enough of an aggregate for them to give off a signal for the positron emission tomography, for the cameras to even pick up that signal. And so what this pattern sort of looks like to me is that there's probably a recurrence somewhere. It's very slow growing, and the aggregates are so tiny that we're just not able to localize it. What would be the utility of doing a PSMA at 0.7 versus 0.1 with a very slow doubling time? I don't think that there's that much of a difference. I think that we always think let's try to identify recurrence as early as possible, because we do know that early salvage does improve outcomes. But again, you have to put all of those factors into place as far as your doubling time, your length to initial recurrence, that type of a thing. I think all those parameters are very favorable for you. It's indicated at any point that we have a rise in PSA, so it certainly would be an on-label triggering. So I think I would continue to have that discussion with your urologist or your medical oncologist or radiation oncologist, whoever is the person that's really the most closely tracking your PSA, as to when to trigger the scan. I would be comfortable doing it if you've gone from 0.4 to 0.7. I'd be comfortable doing it at 0.7. I don't think you have to wait to 0.1, but again, I think that you have several reassuring factors under your belt that if you waited to, 1.0, if you waited to that point, I would never guarantee this, but I'm not sure you're going to lose that much ground.
Okay. All right. Thank you.
Yep.
Bruce takes us back with his question back into not only theranostics, but I'm going to hijack your question here, Bruce, because Dr. Metzger isn't here tonight, and he's been talking to us about PSMA-guided SBRT. Is that on the horizon? Where are we seeing the juncture, not only with theranostics, but other kinds of radiotherapies?
Yeah, absolutely. So, so I think this is a really, really exciting space, because if we have a PSMA PET scan that shows a local recurrence, say in the pelvis, in a lymph node, our default was to, before PSMA PET imaging, our default for lymph nodes in the pelvis, or even if you had a negative conventional imaging workup, the default was to give radiation with a boost to the prostate, pelvic radiation with a boost to the prostate. In this PSMA era, we're able to really start utilizing and really put our money where the money is, whatever that is, utilizing PSMA PET for precision medicine and precision treatment. And so I think it's a really exciting space to use focal therapy such as SBRT. If you have a solitary, or even if you have oligometastatic disease, 5 or less lymph nodes, and you can radiate them with SBRT and save sort of a wider radiation field and all of the potential side effects and complications that come with that, I think this is a really, really exciting space for us to be in. I think that's there are several clinical trials underway looking at SBRT and oligometastatic recurrent disease. So yes, I think it's a really exciting space. I think it's moving us toward precision medicine. I think anytime you can avoid a wide field of radiation, and have, this is all assuming our outcomes are just as good, but have similar, if not better outcomes, that's just gonna, be beneficial.
Outstanding. I don't see more questions in chat.
I can answer this. Is PYLARIFY used in theranostics the same way as gallium PSMA PET CT? It is. So we only have one currently approved radioligand, PSMA targeting radioligand therapy, and that's Pluvicto. The current guidelines for both the Society of Nuclear Medicine and Molecular Imaging, which is a big nuclear medicine professional society, as well as the National Comprehensive Cancer network. There we go. I had to go through my acronym, as well as the NCCN. Both of those guidelines do say that eligibility for Pluvicto, so for the only currently approved radioligand therapy, you can either use PYLARIFY or gallium-68. They're both equivalent for determining eligibility for treatment.
Outstanding. Before we make a last call for questions, I do want to urge people, because I see some new names in the audience tonight, I do want to urge you to go to prostateforum.org. That's prostateforum.org, and sign up on our contact list for our newsletters, our meeting announcements. Join us for our support group meetings on the second and fourth Tuesday of every month at 5 p.m. Pacific time. And you'll be able to view this presentation on our website under presentations. Along with that, it looks like we got another question here about, okay, Ira, if you'd unmute yourself, you asked a question about PYLARIFY injection.
I looked at your site, doctor, and it said something about PYLARIFY injection. So what's that?
Yeah, so PYLARIFY is our PSMA PET CT imaging agent. So it's the commercial name for our imaging agent
And when
that
it says
targets PSMA.
when it says injection, does that mean that it's given in a different way?
No, they're all by injection. They're all injected into the patient and they travel through the bloodstream. Yep,
Okay.
they're all injection. Well, thank you, everyone. Really appreciate it.
No, thank you. Thank you for joining us so close to Easter, and everybody else.
Likewise.
If there are no other questions, I'd like to say good night, and you will find this presentation posted very quickly on prostateforum.org under our presentations pull down. Look forward to seeing you all at the meetings on the 2nd and 4th Tuesday for support group meetings, 5 p.m. Pacific. Have a great holiday.
Thanks, everyone.
Thank you.
Bye.
Thank
you, Doctor. Thank you.
Thanks. Bye.
Quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends.